2021, the year ahead, COVID and EMS. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, Tuesday's critical care rounds will be on successful staffing models for severe pandemic surge, a current update on that. And then on Thursday, on our emergency department rounds, we're going to be having leadership from the National Association of School Nurses giving us an update on school nursing. Please note that we do have an HHS ECHO outpatient therapeutics mini-series. Those are held on Wednesdays, but this coming Wednesday, understand they will not be held this coming Wednesday. I'll now turn over to Dr. Strumminger.
Thank you, Rick, and welcome everyone, and special welcome and thanks to Alec Isakoff for joining us today to share his reflections on the year ahead, and to all our panelists. Just to quickly review our usual housekeeping items. The more you share your questions and comments with us, that'll make our discussion more interesting following Alex's presentation. So please put your questions and comments in the Q&A and we'll be monitoring that. If you've got any technical or logistic issues, mention those in the chat. We'll try to help you resolve them. We're recording today's session as we always do, and your attendance is consent to be recorded. Thank you. Today's presentation and the recording will be made available on the Clinical Rounds website, and we'll share a link to that in the chat, and it should also be in the announcement. CME and continuing professional development credits are available through the University of New Mexico. We really appreciate the feedback you give us when you complete the 2 to 3 minute survey leading up to getting the certificate. That will be available for 48 hours. We really, really value that feedback, so take advantage of that opportunity. There should be a link in the email announcement that went out today, and we'll share it about 15 minutes before the end of the session. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical and non-commercial. Thanks for that. And just a note about data use. We keep your individual data confidential. We take data stewardship very seriously. And what data we do share with Rick and Asper is all de-identified. As Rick mentioned, NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in these rounds. They have their own terrific webinar series. We'll share a link to that in the chat. And they've got an archive of all the sessions they've done over the last year there. And you'll be able to find announcements for upcoming sessions. Also, the Association of American Medical Colleges is a partner in this initiative. They've been developing and maintaining a clinical guidance repository since the beginning of the pandemic, and it's a great resource. Rick, back to you for today's crowdsourcing question. Sounds like Rick maybe paused there for a moment. So maybe I'll go ahead and mention the crowdsourcing question for today is, what is the most common reason you've heard from fellow EMS clinicians for not wanting to get the vaccine? What is the most common reason you've heard from fellow EMS clinicians for not wanting to get the vaccine? Please share your experience with us in the chat. And looks like,
Thanks.
John, do you want to, I'll pitch.
I'll jump in real quick. Thanks, Bruce. I really appreciate that. While we're waiting for Rick to come back on board, we'll go around real quickly to the panelists. And if you would please take yourself off mute, just quickly introduce yourself, and then we'll go into Alex's presentation. Dan, we'll start with you.
Hi, I'm Dan Gerard, and I'm the president-elect for the International Association of EMS Chiefs.
Thanks, Dan. Doug?
Hi, everybody. Doug Kupas. I'm an EMS and emergency physician from Central Pennsylvania with Geisinger Health System. I also serve as the state EMS medical director for Pennsylvania, and I'm on these as a board member of NAMSP for the last year.
Thank you, Doug. Bruce?
Bruce Evans, I think that.
Oh, I'm sorry. Yeah, Bruce Evans.
Yeah.
My apologies.
Sorry about that. Bruce Evans, president-elect and National Association of EMTs and fire chief at the Upper Pine River Fire Protection District, Southwest Colorado.
Thank you, Bruce. Matt?
Hey, Matt Savatsky. Bruce misspoke. Bruce is the current president of NAEMT. I am the immediate past president of NAEMT and one of the executives at MedStar in Fort Worth.
And we just keep you both on so you can keep each other honest. Thank you. Appreciate that. David Gerstner.
Greetings, David Gerstner, Dayton Fire Department in Ohio, and I'm the regional MMRS coordinator for West Central Ohio.
Thank you very much. Jeff, if you've connected with us and are on now, please introduce yourself.
Hi, good morning, Jeff Beckman. I work as the Associate Division Director, EMS with CDPHE in Colorado, and also a board certified EMS physician and ER physician. Happy to be here. Thanks, John.
Great. Thank you very much. It looks like Rick is still working on getting his connection. So apologies to Alex because I don't have your bio in front of me. Alex Isakoff from Emory University, Department of Emergency Medicine, and the EMS team lead for NETEC. Professor of emergency medicine at Emory, and Alex, I don't remember everything else. Alex has been with us for many, many months as one of the subject matter expert panelists. And we've asked Alex to sort of put on his crystal ball or look into his crystal ball, put on his pontification ball cap, and give us some thoughts and ideas that we can talk about where EMS may be going forward. And Alex, I'll hold just for 1 second. Rick, you're back on. We introduced the panel. I just destroyed Alex's introduction, but anything else you may want to have to say before he starts?
Thanks, John. Sometimes government VPN systems aren't helpful. And I'll leave that there. Yeah, I do want to say one thing about Alex, and had intended to until I like totally zoned out there for a while. It's important for participants to know Alex and infectious diseases in EMS is not just like the pandemic thing. People should be aware that the first EMS professionals from the field that the White House reached out to when the first Ebola patient came to the United States of America was Alex Isakoff. his depth and breadth of understanding of infectious diseases in EMS far exceeds anyone that I know. So over to Alex.
Well, Rick, thanks for that. And John, thanks for your introduction as well. John's was spot on. Rick, yours might be overly generous, but I definitely appreciate it and appreciate being here with you all today. I have always considered it really an honor and a privilege to sit as a panelist on these rounds. I mean, there are so many subject matter experts in EMS and representing different professional associations here on this call and providing different perspectives on the challenges the EMS community has faced through this pandemic. Really to sit with this group is again an honor and privilege. And so is being invited to give this presentation today. So let me quickly put my slide deck up and make sure everybody can see that. I think we should be good now. And this is trying to look at the year ahead, what it means for the EMS community that we are, still in the middle of a COVID pandemic while we may see light at the end of the tunnel. And I think it's important to qualify this and provide disclosures. While I am an emergency medicine and EMS physician, and as Rick has said, I've really immersed myself because I think this is so important for the health and safety of EMS. The EMS workforce to understand communicable diseases and how to interrupt transmission and how to work safely in the workplace. That's the expertise that I bring to this. My disclosure is I am not a certified fortune teller or certified soothsayer. Why I don't hold those certifications may very well be clear to you when these 15 minutes are up. But what I'm hoping is that we'll answer some questions that people may have about what we think will be evolving over the next year, and then together with the panelists answer your questions live and maybe get closer to the truth. At a very high level, I think the three areas that I want to cover are infection prevention, because I think this is important. Where are we going with vaccine and therapeutics and variants? What are our expectations around PPE? What about other high consequence infectious diseases? I think the other thing that I want to just touch on again, this in 15 minutes, is we have been as a community learning, all year long. We are recognizing, things that we had in place that needed to be adjusted, and, gathering the best available evidence to adjust our sort of operating paradigm and our infection prevention paradigm and dealing with PPE shortages and everything. We've learned a lot and we've made adjustments to the year. At some point we need to sort of take a reckoning, really pause and look back and say, well, what have we learned and what should we continue to work on, sort of in the sort of fashion of an after action review. And there's so much that could be listed there, but I raise a few with regards to wellness and resilience, supply chain integrity, and crisis standards. And then I think the other thing that's clear, and this is not just limited to EMS, but this is true, across so many different communities and so many different industries, is that the COVID pandemic, really served to accelerate trends that were already in place. And we're seeing that in EMS too. This has been described in much greater detail and with much greater expertise than I would be able to do in the short time that we have. But we've seen accelerations in telehealth, mobile integrated healthcare, and even reimbursement models. And we should latch on to that acceleration and really work to continue to craft this system of emergency medical services and care we're able to provide our citizens in a way that makes more sense, and let's get reimbursed for care that is high quality, that has high patient satisfaction, that yields good outcomes, and that just makes sense. And I think we've seen accelerating trends in these areas, and we'll just touch on that in this 15 minutes that we have as well. Let's start with infection prevention. I mean, a year ago, we said the real game changer is going to be when we have an effective vaccine, a safe and effective vaccine. And we have a safe and highly effective vaccine. And someone asked, hey, did you get permission for this guy in the photo, to use his photo in the talk? And people who know me, that's me. I got my 2 doses of Pfizer because that's what was available to me. And And we've had good echo rounds on the safety of these vaccines, and how many tens of thousands of volunteers in randomized controlled trials helped to develop that database of why these vaccines can be regarded as safe and why they can be regarded as effective. And I got vaccinated, and let me just say, it's been said on previous rounds, you should too. What in the coming year of the variants? Well, we will see more COVID-19 variants in the coming months, and I would go as far as to say we'll see additional variants sort of coming on the scene, maybe for years to come. And there will always be an effort to keep up with the science on how these variants are impacting the effectiveness of vaccine, how these variants that will emerge will impact the effectiveness of various medical therapeutics. And that's important, and we'll continue to gather that information and digest it and incorporate it into our healthcare delivery model. And the good news is right now, with regards to the vaccines that are under EUA in the United States, the Pfizer, the Moderna, and the J&J, all of them, to include the different variants that we've seen, are highly effective at preventing death, are highly effective at preventing serious illness and hospitalization. And that is so critical for us as healthcare providers, for us as family members and wage earners and people contributing to our community for our loved ones. Let's avoid death and serious illness, need for hospitalization. Let's get vaccinated. Right now, the vaccines are highly effective at preventing those, even among the variants. And of course, our hope is that as new variants are identified, that we'll continue to be able to recognize the effectiveness of these vaccines. And with the technology and the facile way in which these vaccines can be developed, just to use messenger RNA technology as an example, perhaps have the opportunity to modify the vaccine if needed for a prevalent variant that's appearing to escape the effectiveness of some of these vaccines. So some questions are often asked, will we expect to see a booster requirement? At present, there's no requirement for a booster, but we may see, it's possible that because of circulating and emerging new variants, that there's a requirement to get a booster after some period of time. So that's something else that we might expect to see, but that shouldn't be an unexpected thing. We should expect to see it. The question then goes to FDA approval. I can't say that we're going to see FDA approval, which is in contrast to these vaccines being on emergency use authorization in the coming year. But I think there will be a great effort after review of the safety profile of the vaccines and their effectiveness to fully FDA approve them. And that's going to raise questions then about well, one, we'll welcome that news because that means more data has been analyzed at proving and supporting the safety and effectiveness of the vaccine. But then questions will come into, well, will somebody consider for certain activities mandating a vaccine, or will incentives be created for those that are vaccinated? And I think this is another interesting area. Here's a poll that I found just a few days old from Reuters, where, and this is only, it's a poll, it's one poll. I think they had 1,000 people that were surveyed. But of the 1,000 Americans that were surveyed in this Reuters poll, they said, 72% of the respondents said it's important to know if people around them have been vaccinated. And 62% of respondents said unvaccinated people should not be allowed to travel on airplanes. And 55% said unvaccinated people should not work out at public gyms, enter movie theaters, or attend public concerts. And 60% said employers ought to require vaccination as a requirement for return to work. These are sentiments that are being shared. Will be a lot of sentiments shared on this topic. But I think, as the vaccines are moving to FDA approval and our communities are looking for the best pathway to normalizing activity in our communities, this question about, who should be vaccinated and whether or not there should be a mandate will be in the public dialogue. And I think, we need to be prepared to engage in that dialogue in a meaningful way. Now, the other thing I think we can expect in the coming year are just improved medical therapeutics for people that contract COVID-19 and are, either have mild or moderate illness or even severe illness. And so most recently, tocilizumab has been included in the NIH clinical criteria, or sort of clinical care guidelines for patients that, require ICU care. Through medical therapeutics that either neutralize the SARS-CoV-2 vaccine, SARS-CoV-2 virus, or better modulate our body's inflammatory response, we're likely to have better outcomes from COVID-19 infection. And that should be good news to us as EMS providers and professionals as well. In all the years where we talk about and teach about serious communicable diseases, we're always, happy to report when vaccines available to protect us from contracting the illness and to protect us from getting serious ill and requiring hospitalization. It's also, especially helpful to understand that if you do contract the illness, if you do get sick, that there are effective therapeutics, to basically help us get better if we get ill. And we haven't yet seen much discussion about post-exposure prophylaxis or use of any post-exposure prophylaxis interventions for COVID-19. But recently, even though this is really preliminary data and it's not a peer-reviewed publication, but there's a report about an antibody cocktail actually being used in family members who had a test-proven index case in their family. And based on the data that was presented, 100% of family members were protected from contracting the illness after one dose infusion of this antibody cocktail. Now, antibody cocktails are not as convenient as vaccine. They require a 1 hour infusion, 1 hour observation period. You have to go to a special, center to do that and spend time there. But it's also good to see, the evolution of these therapeutics for post-exposure prophylaxis and for therapy for ill people. And we should expect to see that in the coming year as well. Now, while we're dealing with the pandemic, we know that and recognize there are going to be other high consequences infectious diseases that are going to come back into the media limelight. And we are seeing it again, which is a bit reminiscent of how news started to come out about the West African Ebola outbreak in 2014. We're, again seeing countries in West Africa on high alert after an Ebola outbreak in Guinea. We see the U.S. Department of Homeland Security initiating Ebola screening at 6 airports in the United States and funneling travelers from Ebola affected countries to those airports for screening. And while I think at present this poses a really small risk for the U.S. population, the EMS workforce, but it's not zero. And actually what it should be doing is having us sort of dust off our identify, isolate, and inform sort of protocols and procedures, especially if you're in one of these 6 cities that's participating in screening, just so we're ready in case we have somebody that has the right travel history and signs and symptoms, so they can be evaluated. So other high consequences infectious diseases haven't really gone away, and we should get back to our basic education and training around identify, isolate, and inform, and then for many agencies consider what it takes to actually transport and manage a patient with high consequence infectious disease. Question moving on to PPE that's often asked is, well, now that I'm a vaccinated healthcare provider, can I change my PPE requirements? And at present, the answer is no. And I don't want to try to prognosticate when that might change. But at present, we still need N95 respirator or better, gloves, gown, and a face shield. I mean, in the EMS community, we would love to get away from the gown if we could, just because it's another thermal stressor. And we'd like to get away from a requirement to wear an N95 mask and go back to a more comfortable face mask, but we're not there yet. The evidence isn't there to support that yet. Could that come, like when the community has herd immunity, when we're as healthcare personnel vaccinated against COVID, and we, keeping an eye on variants, are comfortable with the effectiveness of that vaccine to protect us. Could we see some relaxation of the PPE? We might. We might see it go to something maybe like we see with seasonal flu, or even like we saw with the novel flu in 2009, H1N1, where PPE regulations or requirements were relaxed from having to wear an N95 respirator with every patient who had novel influenza to only requiring that N95 respirator when you were doing an aerosol producing procedure. There is a possible pathway to having a change in PPE, but the evidence isn't there yet. So let's be diligent about wearing our PPE and putting it on properly, doffing it properly. Let's, in the community, keep wearing face coverings and watching our distance and washing our hands, and let's do what we need to do to try and limit transmission of the disease. Okay. What have we learned over the last year? Tons of stuff. What are the things I want to highlight? Wellness and resilience, healthcare disparities, supply chain integrity, and crisis standards. So this is such an important topic. Paramedics and EMTs, under duress, stressed. I mean, for any, number of reasons. Patients that you take care of, you don't know who has COVID and who doesn't have COVID. You may, have to go to work every day, but you may have underlying medical conditions that put you at greater risk. Sometimes we worked in environments that we didn't have enough PPE. We worried about bringing this disease home to our families, even though our families were, diligently locking down at home. All kinds of stressors. We saw our colleagues, family members, friends dying from COVID-19, or severely disabled after long stays in the ICU. I mean, that is remarkably stressful. And we see, of course, suicides in our profession, which is just tragic. I found, this is just one paper of a number of papers, but look at this statewide analysis from the state of Arizona, where they looked at 350 deaths, 7,800 were deemed suicide. The proportion attributed to EMTs, 5.2%. So 63 of the 1,205 EMTs in that group died from suicide, as opposed to non-EMTs, 2.43% in that cohort. The unadjusted odds ratio for death by suicide among EMTs, 2.43. I mean, 2.5-fold increase in your likelihood of committing suicide as an EMT or paramedic. This is pre-COVID. And then if you adjust for age and gender and underlying medical conditions, the adjusted odds ratio is a little bit better, but it's still statistically significant. More EMS professionals are committing suicide than the general population. 39% increase in the likelihood of suicide among our colleagues in EMS. That is absolutely tragic. And the programs that are in place to try and help us, employee assistance programs, peer support groups, they're out there. There are pathways to find relief. I'm afraid that we haven't found the magic sauce yet, though. How do we beat this stigma of reaching out, as EMS professionals, for reaching out to somebody when we need help? I mean, we work so hard, and it's part of our professional mantra to help others that are in need. And why can't we reach out, when we need help? We've got to work on that as a community. And this is COVID is just another reminder that this is a tragic reality in our community, and we need to find ways to address it. Healthcare disparities are also, always rampant. COVID illuminated that as well. If we look at hospitalizations among Native Americans, 3.7 times that of their white non-Hispanic counterparts. For Black or African American non-Hispanics, 2.9 times, 3 times for Hispanics, and the death disparities from death associated with COVID also increased in those groups: Black and African American, Hispanic, Native American. For a number of reasons. Access to healthcare, socioeconomic status, need to go to work, need to be, because you're a frontline healthcare or you're a frontline worker or an essential worker, getting on the front line. You can't escape exposure. There was even some literature demonstrating that if you were in a minority group, you were more likely to find disruptions in your PPE availability. These are disparities that we, again, COVID illuminated it. They're going to be with us in the coming year. We need to find ways to continue to address it. And then, of course, supply chain integrity and crisis standards. I think, all of you have your own stories, and many stories have been told in these rounds about how we adjusted to the realities of demand for EMS services, long, wall times, EDs overcrowded, interrupted supply chain, and we have to be ready in the coming year that such a thing could happen again. And even just the education and training for our field providers about, what contingency standards are, what crisis standards are. Why are we reusing PPE? Why are we having to have an extended use of PPE? And if we do, how can we do that safely? These are things that, this will come again, and we need to, work on this in the coming year. Here's my last theme before we move to questions. Accelerating trends. As I mentioned before, the pandemic has accelerated trends that were already occurring. Telehealth, mobile integrated healthcare, and reimbursement are among them. There was actually a great echo rounds last week, and actually a number of people, from this group that are among the panelists, including Matt Zavadsky, contributed to that. It was excellent. But expanding use of telemedicine during the COVID-19 pandemic and measuring the impact of telehealth programs on ambulance transports, all in an effort to reduce unnecessary exposure, reduce unnecessary utilization, get to a more appropriate utilization of emergency medical services, and acknowledge for the first time that emergency medical service is not just the transport, it's the subject matter expertise about caring for patients in the out-of-hospital environment. It's the expertise and understanding about where patients can actually get cared for in a timely manner, in the right place with the appropriate resources, and creating systems that get those patients there. Whether that's by an alternate transport or by actual telemedicine intervention. Here is another example. This nice one published in February in New England Journal on mobile integrated health. This is in Los Angeles, but there have been so many good examples of this nationwide. Demonstrating what can be done with advanced provider response units and alternate destination response units and dispatch assisted telemedicine and field initiated telemedicine, and creating a comprehensive system that cares for patients in a way that actually meets their needs better than transporting everybody to emergency departments, that is more cost effective than transporting everybody to emergency departments, that increases patient satisfaction. Our community has not only the subject matter expertise about out-of-hospital care, but also the systems that need to be in place, the utilization of physicians and nurses and advanced practice providers, through our robust emergency medical dispatch systems and transport systems, both traditional, whether that be by ambulance, or non-traditional, get there by Uber or Lyft. Our community knows this. We've seen this science evolve and really be accelerated by the COVID pandemic. And I expect in the next year, we should continue to see an evolution of these sciences to really yield a better EMS system, and perhaps as a consequence of this COVID-19 pandemic, to get there faster than we might have without one, which would be wonderful. And of course, innovation can't happen absent funding. And CMS recognized the need to innovate in the context of pandemic, allowing for reimbursements for alternate destination, the hospital without walls exception. And of course, there are programs that were already conceived and funded prior to the COVID pandemic, like ET3. But we have seen an acceleration in opportunities for EMS agencies to be reimbursed for alternate destination transports. We found people that have been very innovative at being reimbursed for telehealth services. And this is what I expect we'll see continuing to evolve in the coming year. So that's a pretty broad presentation, Rick and John and colleagues. And I, as I always do, I go over, but hopefully with enough time that we have opportunity to take questions from our colleagues around the country and to hear from the panelists about just how far off I was with this prognostication and what I think we should be focusing on in the coming year.
Alex, that is a great, great crystal ball. John, you look like you got your hand like you're about to jump out of the chair. So I'm gonna let John, one comment or question from John, and then because the participants everybody starts dropping off and that kind of thing. I really want the participants to voice their opinions on the polling. And then we'll do the usual conversation among the panelists. So John, and then Echo, be primed to do the polling.
Thanks, Rick, and thanks, Alex. From my perspective, you were spot on, and you gave us a whole lot of things to address. Rick, I'm going to address a couple of the comments that came up in the chat from folks, just to help level set the folks on the call, and Alex chime in when appropriate here. To use the audience to help communicate to their families, their friends, their patients, and things like that. A number of comments having to do with vaccine hesitancy and the fact that folks don't want to get COVID. And, when faced with that, I think it's really helpful if you can be very deliberate about explaining to folks that are concerned about that you cannot get COVID from any of the vaccines that are currently available. There are no viral particles in the vaccine that would potentially cause someone to come down with COVID. So please use that as a reassuring mechanism. Folks don't want to get ill after the vaccine, and reassure them that when you get some of the side effects, and you're not getting COVID, but when you get some of the side effects from the vaccine, that actually is a positive sign that your immune system is kicking in and responding to the vaccine to generate an immune response again, not getting the vaccine itself. And then the third comment that I'll allude to is concern about the long-term effects of the vaccine. And we understand that's a concern, and we don't have enough data right now to be able to address that adequately to put folks at ease. I would, however, observe that we do know that long-term effects from COVID itself can be significant. And there are some studies that are starting to suggest that you can end up with long-term effects even from minimal disease. So the fact that you're not hospitalized, the fact that you don't end up in an ICU doesn't mean that you may not develop long-term effects from having COVID itself. So that's the trade-off between getting the vaccine and having some side effects, and getting the disease and potentially having long-term adverse effects to the disease. Rick, I'm done. Thank you.
Yeah, John, as you went through that, it's like some of that stuff is so straightforward and so simple, and yet it's not getting through. And it's really frustrating, because I know people are going to die because they just not so much anyway. So let's do the polls, and this is a little bit out of character because we usually do them toward the end, but I really want to get them now, and really want you to voice your opinions on this. Okay, so these are focused for EMS clinicians, and for this one, if you're not an EMS clinician, and there are multiple other ones, I think there's 6 or so that are just focused on EMS clinicians today. So bear with us while we try to get some opinions voiced from our EMS colleagues. About 5 more seconds. It's like 35% of you voted. I know we can do better. I think that was a quote from my 6th grade teacher. It's kind of pathetic. All right, 44% have voted. Like, get like focus like away from the email, back on like the polling here. All right, let's stop there. 45% voted, and staffing shortage is the most frequent response, followed by fatigue. Leave it up there for a second so people can see the responses. And you know, it's fascinating. Like 2 people indicated surge was was the most pressing problem today. All right, next. All right, same options, only the question's different. In March 2022, the most pressing challenge for our EMS organization will be. So fast forward a year. And Alex, so I'm gonna like prime you here. After we get done with the poll, and really would, you know, you just gave the presentation. Now we're gonna see some polling results with their crystal balls. It'll be fascinating to hear your thoughts on what you're seeing. All right, another 5 seconds. Let's stop there. Staffing shortage, the most frequent, then I think it's complacency, then mental health wellness. I'm fascinated that there were like 12% indicated financial stability. All right, next question. After the pandemic, I expect our EMS organization's attentiveness to infectious diseases will return to the pre-pandemic level, be the same as pandemic level, be increased compared to the pandemic level. Don't know, not applicable.
While the poll's being done, one of the chat questions was the vaccine myth, rumor, control. Dr. Kramer had actually put, I think, something together, or maybe somebody did, that had some of the big name physicians on it. Maybe it is time to re-up that and do that either as one of these sessions or a separate session.
Matt, thanks. You know, we've done, I think, 2 or 3, but clearly we're not there yet. And I appreciate your it was fascinating. The first time we did it, a lot of information. People really were not just engaged, but I think actually we moved the dial a bit, but clearly we're not there. All right, let's stop there. 55% voted. It's great. All right. Return to the pre-pandemic level, 28%. Same, 34%. Be increased compared to the pandemic level, 25%. That's quite a distribution. Alex, it looks like you got your work cut out for you, though. All right, next. I am an EMS clinician. In general, I believe my fellow EMS clinicians are able to identify when they need professional mental health support. I am appreciative, particularly of the chat about fatigue being a big issue, no recovery time. And actually, while I've talked about it, I haven't put it in the formal suggestion box, but I think everybody needs to take a week off for a month for about a year. And I'm not kidding, actually. All right, 50% voted. Yes, 32%. No, 68%. And to me, part of the reason I felt that question was really important to include was nobody alive has ever been through anything like this. So why would we expect to know when somebody was tipping over the edge? To me, at face value, it seems like that's a challenge for us for sure. Next. I'm an EMS clinician in March 22. A year from now, I expect to be taking care of patients or not. Straightforward. All right, let's stop there. 46% voted. 96 of you voted. 77% indicated they're going to be taking care of patients. 23% not. All right, next. I am an EMS clinician in March 22. I expect to be, and it gives you a number of different options here. Also, because of like the really robust conversation in the chat about the vaccination reluctance, there was a rounds we did a few weeks ago, a couple of weeks ago or so, with our colleagues from Israel. Chaim, I believe you were on a little while ago, may have had to leave, but that one, hearing other countries' perspectives are really, I think, helpful in this dialogue for sure. All right, another 5 seconds. And when we get done with the polling, there might be one more question. I'll go to Alex first to get his thoughts, and then I'll go around the Hollywood squares for final comments before we close out. Oh, that's the last one, Samantha? Oh, okay. All right, let's put this up. 46% voted. %70 in your current position. How about that? I'm not sure it would have been the same if it was 6 months ago. I don't know about that. All right, put that down. All right. Okay, Samantha, if that was the last one, yes? Yeah. Yeah. Okay. All right. That's the last one. And you can take the polling results down. And Alex, what do you think?
Well, I'm glad you asked these questions, Rick, because it gives us, you know, an idea about what other people were thinking, and you know how it has me reflecting on the material that I presented. Actually, it has me realize that the slide on wellness, you know, mental fortitude, is the most important slide, and it's probably the most vexing issue. I mean, you know, some of what we've described as accelerating trends, whether they be in telehealth or mobile integrated healthcare, I think can relieve, you know, some of the stressors, perhaps just as maybe the volume pressure, you know, on EMS agencies, maybe increased satisfaction that the system is delivering, you know, care to patients that is, you know, increasing their better outcomes and satisfaction. But, you know, when I look at the answer to your first two questions, were staff shortages, fatigue, complacency, and mental wellness. And then 70% say that EMS clinicians can't determine when they need professional mental health support. Almost a quarter say they won't be caring for patients in a year. And while 70% of us say that we'll be in the same positions we've been in, 10% say that they'll be retired. I mean, this is the consequence, I think, of, you know, what it means to be a paramedic and an EMT today in a pandemic, and what toll it's just taking on our overall wellness. And people are looking for an exit ramp, right? So if you are retirement eligible, then an exit ramp is you're going to retire. If you are employed as a paramedic, firefighter, you may choose to stop seeing patients if your agency will allow it and just go back to fire suppression duties because you're more, you know, comfortable in that space. You didn't ask, you know, the questions didn't ask specifically about suicide, but tragically, you know, people in our community, our brothers and sisters in EMS, see that as the exit ramp, you know, from all the stress associated with this work. This is maybe, you know, our number one issue for our community to deal with, for the wellness of our community, for our continuity of operations, for the integrity of our workforce. You know, I think we need to address these wellness issues, and we can come back to the vaccine hesitancy piece, or maybe we won't have time in this session. I think that's, you know, another important element that was sort of illuminated here. But I think, you know, for me, Rick, it has me reflecting on direct wellness and mental health initiatives, and then other enhancements of the EMS service delivery paradigm that gives our paramedics and EMTs and systems leaders, you know, the satisfaction that they're delivering good care, quality care, cost-efficient care, operationally efficient care, you know, to the citizens in the community, and trying to get some of this pressure off of our workforce that's causing them to look for an exit ramp.
Alex, I got one like a yes/no question for you. You think, like when the pandemic's declared over and people are starting to pick up the pieces and so forth, you think it's going to be transformational for EMS, or do you think we'll like Band-Aid it and put it back to like pre-pandemic? What do you think?
You know, I think if the leaders in the EMS community, and there are many leaders in the EMS community, you know, don't take this opportunity to see how the pandemic could be transformational, we're missing a huge opportunity. I mean, some trends you won't be able to turn around, right? And maybe that's you know, a good thing as it relates to telehealth and mobile integrated healthcare and reimbursement, and you want to accelerate those. If we ignore wellness of the EMS workforce, the EMS community, if we don't tackle the issues of depression and insomnia and suicide, and I just want to get out of this profession, right? We do a disservice to ourselves, and we miss an opportunity. The pandemic really laid these issues bare again, and we should ensure that it's transformation.
I heard loud and clear the word again, and I'll double down on that. Okay, so for our remaining time, if the panelists, okay, so some of you are on video, some of you are off video. For those of you who are on video, if you can raise your hand if you want to make a comment or a question, and for those of you off video, if you can like at least unmute yourselves so I can see you. Okay, so I think Dan first, and yeah, Dan.
Just three quick comments. Again, Dr. Isakoff, thank you. What a great presentation, and thank you for your clinical leadership. I just wanted to point out, early on in the pandemic, DHS instituted a rumor control website, much to their credit. But unfortunately, that information didn't make it back to the staff. I think that when we start talking about vaccine hesitancy, we have to kind of look at the medical director and how do we restore that person back to the place of trust. When I first started in the field, like my medical director was it, how do we get like old Doc Kramer back into the position of being the trusted resource as opposed to these, other resources that people are accessing. So I think from a leadership perspective, not only the doctors, but, the executive leadership of organizations, we need to restore you back to those positions of trust. I think the other thing too is that when we talk about crisis standards of care, this is the first time that we've had to institute a crisis standard of care over the course of an entire year. If you think about it, we've leveraged crisis standards of care many times. World Trade Center, Katrina, the Las Vegas shooting. I mean, we never would have thought of putting, people, 10 people in the back of the bed of a pickup truck and driving them to the hospital. That is not conventional care, right? So, we have used crisis standards of care, but never for this long a period of time. And so, we really need to start developing our leadership to kind of think in those, to think how that modality would be applied for such a long period of time if we're faced with something like this again. And then the other thing I wanted to just touch about real quick is ET3. It's a fantastic idea. It is a great program. One of the issues, though, that we have to be cognizant of leaders is that it has the potential to create silos of care. And I've heard this from presidents of large ambulance companies that this is an opportunity to create a product line for them. And I think that the hard, brutal lesson that we've learned from this pandemic is that we need to create these interdisciplinary, inclusive systems of care and not have these silos. Our greatest strength comes from systems of care. Dr. Isakoff, thank you again. What a great presentation. I would listen to you, give me instructions on how to hook up my cable box. So
Thanks, Dan. If I'm not zoned out here with the VPN, let's see. Doug, I think you had your hand up, and then Bruce.
Yeah. Thanks, Alex. The first thing that came to my mind, you used the word, that this is basically accelerating. I've been using the word catalyst. I think that, a lot of these things like the ET3s, the treat in place, the telehealth, we're already headed that way, but just like a chemical experiment, this was a catalyst to those. A couple things that were also on my mind that weren't brought up as much are that I think that this has changed education. I think education of the future will be very different. I think many of us miss the in-person conferences. But I think we also see the value of the conferences that have occurred that have had at like the state EMS level that have had more people attending them than we've ever had before because they had the access to get on virtually. So, I think that conferences and education will be changed for the future. We just have to find the sweet spot between the value of the in-person and the value of what we can do virtually. But I think that will change. I worry the most about how we struggle to become human again after this. I think the people that think that, we're going to be wearing masks and gowns and gloves and not ever touch a patient's skin again, I hope are incorrect. I mean, I think that the human touch during patient care is a very important part of what physicians and all healthcare providers have done in the past. And I think that whether it's the handshake, whether it's just a warm human touch as you're examining somebody or whatever is important. And the same for just our communications with people, with our family, with our friends, the the ability to actually feel comfortable enough to get to that point. And I think that we should. I think that, after the AIDS epidemic, everybody was wearing gloves for everything, but we realized that, there are places where you need gloves and there are places where it makes no sense at all. I hope that we don't unnecessarily get to the point where we're ignoring the struggle to be human again. And I was somewhat happy to see that in that one poll, that 0% of the people said they were going to leave healthcare for another career. Some were planning to leave EMS. Some always are planning to leave EMS because they're using EMS as a step ladder. Others are using EMS to stay in the career of EMS. But I was happy to see that there were not a lot. There was 0 that said they were going to go to another non-healthcare type of work. So hopefully that is something positive.
Yeah, Doug, I was surprised by that too, the 0 piece. The other, on the teaching piece, the one thing that I actually have had some long discussions with METEC about, or frequent discussions, not long, but on the teaching piece, and this is absolutely sort of like a EMS specific type thing. It is absolutely the opportunity to identify which skills actually have to be taught in person. You actually have to live and in concert with the equipment and supplies with you versus what can actually be effectively taught remotely. And the whole airway thing comes to mind immediately, because we've been trying to figure out that holy grail for how many centuries at this juncture. So I think that's another one for EMS in the whole context of your comment about teaching.
And I think on skills, it's easy. I think the tougher part is which things happen at a conference with networking and all of the other things that occur outside the meeting that are of value, and how do we make sure we don't lose that by going to all virtual?
Yeah, absolutely.
5 more seconds. I know a flight nurse who's young and previously healthy who had months of post-COVID symptoms. I have a paramedic who's pregnant, who has been post-COVID on limited duty for 2 months now because of continued symptoms, and she's pregnant. And an ICU doc who is relatively young with 2 teenage daughters, who was hospitalized for months on a ventilator and is now down in Florida, from Pennsylvania, but down in Florida, and has just gotten a lung transplant and is celebrating walking 100 feet and having his tracheostomy decannulated. And, I think the people those kinds of things people need to know about, because those ones that think I'm young and healthy and an EMS provider, I'm not going to get it. There's terrible stuff out there from them. And I know those 3 off the top of my head that I know personally.
Yeah, we've had, I think, 3 or 4 long haul patient challenges highlighted on rounds. And actually it was way back, probably in April or May, when Dr. Vikram Mukherjee, intensivist from Bellevue, brought up the long-term consequences many months ago. And Doug, you talk about the clinicians with the long-term effect, but the just sheer number of these patients, and how we've been talking about how it impacts essentially long-haul clinics, but how that's going to impact EMS in terms of its response to so many of those patients. That one, it's almost its own, it's going to be its own 5-volume set of trying to figure out how we're going to do that one. So anyway, Bruce, you had a comment.
Rick, before we go to Bruce,
Yeah, John, sorry.
Bruce, I don't mean to interrupt you. We've had several people raise their hand because they've wanted to comment. The platform doesn't allow that in this setting. So if you've raised your hand, please put your comment into the chat so we can record it and get it. Thanks. Sorry, Bruce.
Thanks, John. Bruce?
Nope, all good. So just a couple of comments. Great presentation today. I agree with those last comments. You know, the long hauler stuff, there's a lot of confusion on that. There's even confusion on what the right therapies are going to be for that. And, you know, whether it's somebody that has like a one-off signs and symptoms, or they got cardiomyopathy, or they're having, you know, they're still winded and their tidal volumes are still experiencing problems. I think all those are going to be million-dollar questions in the future about how EMS engages that and how we even manage the workforce. Again, what kind of light duty assignments. And I have to do an interview here in a little bit with one of the newspapers about what's been happening with workers' comp on these folks. And we've had a lot of challenges with workers' comp in the state of Colorado with people that have been getting COVID that were within the ranks of emergency services. One other thing I wanted to bring up, so just real quick story on the issue of one of our vaccinated fire people from the U.S. Forest Service that we did early, wound up actually testing positive for COVID after his kid got sick. And I think some of the messaging on the vaccine hesitation really needs to focus on the fact that these vaccines are really designed to make sure, like the speaker said, not to make you sick. Doesn't necessarily keep you from contracting COVID, but you're not going to get hospitalized. You're not hopefully going to get critically ill from it. And there's a lot of people that don't understand that. They think this vaccine is in the world of the traditional vaccines, where it's going to prevent you from contracting the virus. And that's just simply not true with the bulk of what we've already vaccinated. So that messaging about that you can still get it, you can still carry it. You're probably not going to get sick, but if you got family members around you, you potentially they can contract it. And then the last thing I would say, and I brought this up on one of the other previous calls, is that, you know, mutations are a great concern. And once we get, you know, how many mutations are there to the, you know, if we get to an incident where this becomes a totally different virus, or it becomes a much more deadly virus than it currently is. And I know that the virologist that was on a couple of weeks ago was talking about that is totally random, but it just seems to me somebody in some room somewhere that's a propeller head with a Cray supercomputer or 3 Apple computers that are linked together in some national lab could put all the inputs in to how these vaccines have, or how the viruses have mutated, and give us an estimate of just a computer projection of, is it going to be 10 mutations? Is it 20 mutations before we get something that's going to be a lot more deadlier? Because I think that is going to be probably, hopefully not the other shoe that drops when there is a mutation that we get totally caught off guard with, that develops another sign and symptom to this other than respiratory disease. Say, for example, you know, something that becomes hemorrhagic, or something that causes kidney failure or attacks a specific organ, or even causes encephalitis. You know, you get one of those that mixes up with this, or you get that mutation that happens, and then it's a whole new ballgame of signs and symptoms and therapeutics that have to be developed on it. So I really, really wish that we had somebody somewhere that had one of those computer capacities that knew how to do those inputs and give us, you know, some kind of best guess statistical analysis on it.
Yeah, thanks, Bruce. And I'm hoping somebody's doing that. One comment you made about the on the long haul patients, and I actually hesitate to use that phrase, long haul. I'm not sure that's like the long-term consequence. Or at least I'll try to work on that phrase. Those long-term consequences. You know, NIH has thrown a lot of money at trying to understand those consequences. And here's the problem. It's like, the problem is, it's going to take a long time for that research to actually happen. And in the interim, we're going to be like taking care of these people. So it's like the beginning of the disease in some bizarre respects. And that, like, we have to take care of them independently of like the research funding, you know? It's like a huge challenge that we have. And Bruce, I mean, I think your warning is sort of like warning shot over the bow, like be prepared for surprises. That being continue to be humbled and by this virus is like really important. And quite frankly, Europe is being humbled once again right now. So yeah, we're not
And
done.
when we talk about long haulers, Rick, we've been chasing that underlying cause for Kawasaki's for decades. And, I don't think that there's still a definitive answer on Kawasaki's. I think the mechanisms are understood, but, there seems to be multiple ways. So again, is this the same situation where, we're going to be chasing the causes for long haulers post exposure or post COVID illness for decades, trying to figure out what exactly is the mechanism that's causing all this stuff.
Yeah. I don't have an answer to one question that's in the QA. What can we do to expand the role of point of care testing for COVID and flu to reduce the numbers of transports? I don't have the answer to that, other than I hope it doesn't get lost in the shuffle of all the other priorities that we have, because it's like really critically important. So, hey, John, you got anything final before I close out? Yeah. Hey, this was really, one of the more sort of like thoughtful discussions and presentations we've had in a long time. And thanks to participants. Really, the chat's just been like, yeah, crazy, wonderful dialogue. And appreciate Bruce, you mentioned it, or recently we were talking about like the tone of the chat is exactly the kind of thing that I'm really proud of our participants for. Really proud of you guys and gals out there. The tone of it is just like, because it could go so far south so quickly, and you haven't allowed that to happen. So thank you to our ECHO colleagues. Thanks always. Wow. And by the way, as I think about ECHO, heads up, March 24th will be our 1-year anniversary. We actually don't have rounds on that date, but we'll celebrate that 1-year anniversary or recognize it the day after on March 25th on rounds. To our panelists, great discussion, really great, insightful discussion. Alex, thanks so much. Obviously, you broadened people's horizons on the way forward and what we might be faced with. So any last word from you, Alex, before we finish?
No, I say keep doing these rounds. It's a great platform for sharing best practices, sharing thoughts from the entire audience that participates in the panelists. It's a great rounds. Thanks for having me.
Yeah, absolutely, Alex. We'll see you on the next one all. Bye.
Thanks, everyone.